Over 70,000 adverse events related to puberty blockers have been ignored by the FDA. Are they the best option for children? My name is Rowan Allen.
My name is Savannah Postwaite.
My name is Ava Bryan.
And my name is Bree Scott.
These statistics come from the 2024 National Survey conducted by the Trevor Project, which is the largest suicide prevention and crisis intervention organization in the U.S. for LGBTQ youth. On this graph right here, you can see the disproportionate rate in which transgender teenagers face problems versus their cisgender peers. This graph deals specifically with suicide ideation and attempted suicide, and you can see between cisgender men and transgender men the high percentage of difference, with an almost 25% in ideation and 11% in attempts. And this is also clear when you look at the symptoms of anxiety and depression as well.
According to the Murdoch Children's Research Institute, puberty blockers are medications that stop the body from producing estrogen and testosterone. If adolescents take these medications during puberty, then bodily changes associated with puberty are prevented.
So the question that we've been researching and that we propose to you today is, should adolescents ages 13 to 17 be permitted to use puberty blockers for cases of gender dysphoria?
Our group's consensus is that puberty blocking treatments should not be the first recommendation for children, and that there should be some other recommendations such as therapy before diving headfirst into that.
The origin of puberty blockers dates back to the 1980s, where it was used for cases of precocious puberty, infertility, and then prostate cancer in the lives of young teenagers. As we move forward in the 1990s, they were then used for cases of gender dysphoria in the lives of transgender teenagers. Some of the other uses that were previously mentioned was infertility, and a very specific case that it deals with is endometriosis, which is when the outer layer of the uterus is covered and lined by tissue, and it causes pelvic pain, and it causes the children to not be able to have children in their future. Another case is prostate cancer. It can, if it is found in the lives of a young teenager, it can be prevented by using these puberty blockers. And then it also deals with the overall overdevelopment of children, which it causes mental health when children do not know what is happening to their body and they're experiencing changes.
A cohort study conducted in the Netherlands in the late 1980s called the Dutch Protocol is what revolutionized puberty blockers for the treatment of gender dysphoria in the first place. Gender dysphoria is categorized as the uneasy feeling someone gets when outer characteristics, such as like sex characteristics, do not match their chosen gender or what they feel like is their chosen gender. Puberty blockers are used to help pause those distressing effects that happen, which helps with treating gender dysphoria and body image issues. And researchers have also found that it is tied with significant mental health improvement, such as reductions in anxiety, depression, self-harm, and suicide ideation and attempts. And has also found, like, as they grow into adulthood, that the access to care is paired with better objective and subjective overall well-being.
Some physical effects of taking puberty blockers are that they temporarily stop the hormones that trigger once puberty begins. One key effect is a decrease in bone mineral density, especially weight-bearing areas such as the spine and hips, which can lead to lower Z-scores during treatment. After starting hormone therapy, bone mineral density partially recovers, but trans girls who are originally assigned a male birth have a less complete recovery than trans boys do, who are originally assigned female birth. Puberty blockers also cause temporary shifts in body composition, which can lead to an increase in subcutaneous fat and a decrease in muscle mass. Overall, puberty blockers pause but don't permanently halt physical maturation. Ongoing monitoring with bone scans, calcium, vitamin D, and exercise is essential to manage these reversible effects. According to a 2023 study by JAMA Networks Open on transgender adolescents, this graph shows how bone mineral density partially recovers over time when taking puberty blockers and then gender-affirming hormones, with trans girls faring worse.
A few concerns for adolescents taking puberty blockers is the overall lack of sufficient evidence suggesting that it's safe for kids, the many physical effects such as the lowering of bone density and muscle mass, as well as brain swelling, some cognitive and psychological effects such as the lowering of a child's IQ permanently, as well as post-treatment regret that we see later in life, the fact that there are safer alternatives. All in all, the benefits simply don't outweigh the risks. Our first solution that our team considered was to ban puberty blockers completely and implement some other course of action.
The next one was more research. The reason for more research is because long-term studies are scarce, leaving uncertainties around fertility, height, cognitive development, and for reversibility. Also, disparities in access and outcomes highlight the need for more rigorous, diverse research to guide safe, ethical care. Without it, the medical professionals risk uneven health results for the transgendered youth.
Another solution that we considered was therapy alone, which gives the gender dysphoric teenagers time to speak with a mental health professional instead of jumping straight to puberty blockers and possibly damaging their bodies for a lifetime.
Our final solution that our group has concluded on is the pairing of puberty blockers with therapy. As while we recognize the risks, we also recognize the benefits that come with both, as therapy helps deal with other mental health problems that they may face, such as unsupportive home environments, and also with a year of mental health evaluation before starting, it helps both the teenager, their parents, and their medical health professionals determine if this option really is the best option for them specifically and what they face. This can also be used to help us gain more research, as with the medical monitoring that will be required to make sure that it's not harming them and make sure that their treatment is adjusted to what they need. It can help us gain more research in the overall long term.
One of the limitations that we found when researching the pairing of therapy and puberty blockers is that there's not much evidence regarding the benefits of using therapy. So if a teenager were to go to therapy first, we don't know how well that would work. And so they might just end up using puberty blockers anyways, which is what we're trying to avoid.
This also helps support teens' autonomy, as they can be informed on this course of action and decide whether it's the best for them and their family in their own personal situation. It can also help lead with harm reduction, so that when they do start it with the medical monitoring, if a symptom comes up that needs to be treated, that the puberty blockers are making worse, their treatment plan can be adjusted.
In conclusion, there isn't enough research to decide whether gender dysphoric teens should 100% use puberty blockers, but on the contrary, there isn't enough research to decide whether we should ban them. So for the mental and physical well-being of the transgender teens, they should do therapy before starting treatment. This gives them two advantages. First, it gives them time to decide whether or not they actually want to use puberty blockers. And second, if they do want to use the puberty blockers, this gives time for the medical professionals to do more safe research. Thank you for listening.
Thank you.
Thank you.
Do you have a works cited?
Yes, ma'am.
Thank
Yeah,
you
we
so
will.
much. Okay. Oh,
2 pages.
so thank you guys for sharing. That was a lot of really deep information. So I want to ask you a few questions. I'll start with you, Rowan. Can you describe how the content of your team presentation was changed as a result of group discussion?
Well, I know that me and Savannah really thought that puberty blockers should not be used at all because of all the dangers that we listed. And whenever we started looking at Bree and Ava's research, we really delved into the mental and like the suicide part of it, how there's just so much that it would really be too risky to completely take them away. So that's how our minds kind of shifted on the matter, and then we came to join with the therapy and the puberty blockers.
Thank you. So the next question is, can you reflect on your colleagues' work and tell me which one had the greatest impact on your overall understanding of the problem that your group identified, Savannah?
I would say it was Ava's, because the mental health and the mental aspects of the transgender teens are just overall the most important thing about this, because in the long term, mental ability is far more important than physical. And also her paper brought my eyes to see that like suicide, if we took away the puberty blockers, then suicide ideation, anxiety, and depression could go up for those people, and we don't want that to happen at all. So I really think that her paper was the best one.
Thank you. So Ava, can you give me an example of a compelling argument from one of your peers' individual research report that you decided to exclude from your team presentation and why you decided to exclude it? Would you like for me to restate?
Thanks.
Can you give me an example of a compelling argument from one of your peers' individual research reports that you decided to exclude from your team presentation and why you decided to exclude it?
Yes, ma'am. So I think that Rowan's paper specifically, because he dealt also a lot with neurological effects besides Savannah, which dealt with physical effects. And while we included Savannah, like a lot of her examples, I feel like we kind of like look over Rowan's, and that also kind of affected how I viewed it, because they were sort of on the opposite side of me. And so like looking at that, I really did have to take into consideration whether this was the best option and look at how it could affect them, like just not on the mental health field alone, but also physical and neurological. So I think that that was a good thing for me personally, like forcing me to view the other sides.
Okay. All right, so Bree, thank you for sharing, Ava.
Yes.
Can you, if you had more time, what additional research would you conduct as a team? If you had more time, what additional research would you conduct?
I think we would probably look more into therapy. We talked about if we had another person, we would do the economic perspective. So I feel as if we would research more on the cost of therapy, and also we would look deeper into how well it works, because we did skim over that topic just a little bit, but if we were to go more into that, I feel as if we would have more evidence behind the reasoning for using therapy and not some other solutions that we came up with. Like medical monitoring was in Ava and I's paper, but we decided to leave that out as well because of the better solutions that we found when looking through all 4 of our papers.
Thank you for sharing.